My name is Yitka Graham. I wear about 10 hats, but I'll just tell you about sort of 3 of them. I'm the National Research Lead for BOMS. I'm an Associate Professor of Health Services Research at the University of Sunderland. And my newest title is I've just been made a visiting professor at the University of Anahuac in Mexico. I've got some research, international bariatric collaboration going on, so quite proud of that one. What I'd like to do today is talk to you, not sort of use sort of myself as a platform, but I was asked to talk about undertaking research. So I'm aware research is one of these things. We have people that probably do more research than I do. It's a mixed level of skills and knowledge. So I've really sort of tried to pitch it in the middle. So for the ones who are really research active, I apologize and feel free to sleep. And for those just starting out, I hope you sort of realize that research is just not something that other people do. It's not for we can all do research, and we should be doing research in our everyday practice. But what I wanted to do is talk to you about contraception and bariatric surgery, not as a research topic, but actually it was something that I sort of stumbled across, and it was sort of based on knowledge I had, work I used to do, and I realized nobody had really done anything about it, and it was sort of there, and I took the opportunity and got some publications, and it really sort of my research trajectory increased as a result of doing it. So I really sort of just want to talk you through that journey sort of as an example of how research can be done and identifying opportunities. So it's really just to talk through a worked example of clinical research from an idea through to dissemination, and just share some of the resources available to AHPs. I do work for the National Institute of Health Research, so I'm quite biased towards the resources there, but they're quite widely available and they're open to everybody, so I will give you some links. I'm quite happy to have the presentation shared if people want those resources afterwards. I will disclose that I have received funding from Roche Diagnostics, Metagenics and Smith & Nephew for research I've undertaken. Just to sort of with developing a research question, so this is sort of on the left, things to sort of ask about. So really I would ask you, what sort of things do you see in your day-to-day practice? And I will say I'm a qualitative research, so never mind what the surgeons do, I view the world from a totally different perspective. And just not just what you see, but what's going on? What are sort of the actions go underneath that? Nothing's ever sort of at superficial level, but if you just sort of flesh it out and dig a little bit deeper, and just sort of very basic things, the way that I looked at things. So I'm not a surgeon, I'm actually not an AHP, but I have a research post at Sunderland in the Bariatric Research Unit. So not sort of being aligned to a particular perspective can be quite a good thing, because I don't have any biases or any assumptions about it. I go in and I sort of ask. So I think I sort of looked and I thought, well, you know, what's going well? There seems to be a lot of patients coming through. There seem to be a lot of operations. There's lots of people in the support group. Everybody seems really happy. So, you know, things on the surface look like they're going quite well. And then I started thinking, well, what might work better? What are they doing that they could be doing better? But actually, I really don't know. So I just sort of started asking a few questions, not in a confrontational way, but just tried to invite open conversations. And then sort of through that, it was sort of knowledge I can build on. Now, I will say I spent many, many happy years in the pharmaceutical industry, which is why I went into clinical research. And in that background, it was in women's health. And actually, as I was sort of looking and talking, I thought, well, actually, there's a lot more women coming in here than men. And then so I started asking questions. But again, it's probably just biased thinking, I really enjoyed my time in women's health. Can I bring any of this into bariatric surgery? And that is the honest truth. And so I sort of looked and I said, well, what are the ages of women that went through? So you sort of have like from menarche to the menopause. We don't operate on anybody really under 18 in the UK. So that sort of removed a cohort of women. And then it sort of, I thought, well, actually, most of them seem to be coming through. They seem to be in their reproductive age years. So started asking questions, doing a bit of reading. And, you know, it wasn't just in our unit, it was national and it was global. That reproductive age women were the cohort coming and seeking surgery. And I thought, well, actually, if they're coming in, they're having surgery, and, you know, I'm reading all these things about the difference between bypasses and sleeves and bands and, you know, absorption of drugs. That sort of took me back to my pharma days and looking at malabsorption. I says, well, if they're not supposed to become pregnant, wouldn't they, you know, what sort of contraception do they take now? I sold contraception. So again, it was just things, I guess, my sort of knowledge base, my experience, I was sort of didn't really, I hate losing any sort of learning. I thought, is there an opportunity to push it in here and sort of build upon that and take it into a new skill? So sort of we're quite selfish researchers, aren't we? So, but then I thought, well, actually, this isn't really being selfish. There's something here. There is information, but there's no knowledge. And I think, and again, it's probably your psychological guidelines are really sort of a very good example, a very similar thing, that there is a lot of knowledge around, information about psychology, but from what you said today and whatever, there's not a lot of knowledge. So which is great why you've done what you've done. Again, that's underpinned by research. So again, we knew that medication is affected by mechanisms of surgery. So all these things started coming together. I'm like, well, is there any, can I do some research here? And I thought, well, nobody else is. So I'm gonna get in there and then sort of claim it. So I started looking again. I think it's really important to look at what evidence exists, what's going on, what's there, what do we know, and what don't we know, and just really try and find those gaps. So what is known, what gaps there, what new knowledge could be gained, and again, looking at policy documents, so looking at NICE guidelines. There's nothing in the NICE guidelines about contraception. What we also know, we don't know, there's unknown effects of surgery on mother and baby. So there's a theoretical risk of nutrient deficiencies and rapid weight loss. Now, a surgeon, a dietitian, everybody understands that, but we don't know, but we don't do clinical research on pregnant women. That's just a big no-no. But there was just really no consensus on what the ideal contraception was, what the ideal, we're still thinking about what is the ideal time. It's up to 2 years, but everybody has an opinion about that. But then also, the more questions I started asking, I would ask the surgeon, I said, what about reproductive health? They said, we're not gynecologists. If we wanted to be, if we wanted to deal with women's health issues, we wouldn't be bariatric surgeons. We understand that, but that's not really what gets us out of bed. We like to cut people open. We like to, and that's fantastic. That is great. And keep doing what you're doing, because it keeps me in my job. So keep doing it. But then I thought, well, but the bariatric set, but we acknowledge this is important, but this isn't something that we need to get involved with. And I said, well, who's doing it? And they said, well, sometimes the nurse speaks and sometimes the dietitian does. But then I went and asked sort of the same questions. And he said, well, we know it's important, but it's not our area. It's not our area of expertise. And we kind of don't know what to do. So, and everybody said, we're not comfortable with it and we don't have a lot of knowledge. And so I said, I went back to sort of people I knew before, and I went to the family planning colleagues and the gynecologist. I said, well, what do you know about bariatric surgery? And they said, absolutely nothing, because we're gynecologists. We're not bariatric surgeons. So you had exactly the same argument from two different perspectives. So what I really need to do is get some family planning doctors and some bariatric surgeons and myself and sort of pull this evidence together and get it out there and just ask. So I had my first publication, which was a commentary. It was actually what used to be the Journal of Sexual and Reproductive Healthcare. And that was actually probably the most poignant of my publications, because a friend of mine was the editor and she died 2 years before I finished my PhD. So the fact that my first piece of work was in her journal was something that really, really meant the world to me. And I think once you've got one publication, I'm sure Jane's looking at me, you want a few more, because it's just the best feeling in the world when you get that acceptance letter, when you pick up the journal and you see it in print. It's fantastic. It really is the best feeling in the world, knowing that what you've done is out there. People have actually peer reviewed it, and you're not stupid. People understand and accept what you do, and it's great. So that was my first publication. And then you kind of don't want to stop. So I thought, well, what do I do next? I've got this information, and then sort of reflecting back, I've got bariatric surgeons that don't know about contraception, and I've got family planning doctors that don't know about bariatric surgery. So, let's just unpick, let's dig a bit deeper and look at the way you can do things. So how many, it's quantitative, so you're after numbers. How and why is qualitative, and then you've got a bit of both, which is mixed methods. And I thought, actually, I do need a bit of both, because I need to understand what's going on. So that's qualitative, but then it's not just people in my unit. So I needed numbers. So it was very much mixed methods. It's also really important to consider, without getting too academic, your philosophical frameworks for a study. Do you want to do something sort of lab-based where you go in, it's very deductive, you have a hypothesis, you want to prove and disprove it? Or do you want to go inductively, have sort of an idea and you want to unpick it and get it further? So there's two ways of doing it. I lean towards the inductive approach, but that's sheer bias, which I acknowledge. But there's not a right or wrong way to do things. It's the research question and what you want to find out that dictates the methods that you use. And I think it's also important to consider different perspectives. So you can look at it from the patient perspective, But then also, especially with this, I thought, actually, it's not this is a staff problem. This is a clinician's, but I want to speak to the clinicians and see what they think. Because actually for this, it's not what the patients think, it's what the clinicians think. And there is also in other areas of research, never underestimate the role of carers or friends or family. They're an underrepresented group in research. And I think if you look at the stigma of obesity, you look at the complexity of the patients we deal with, you think of the social adjustments and how life-changing bariatric surgery is, there is a lot of work that I think we could be doing with friends and family members. So the next piece of work I want to do to understand what bariatric teams know about contraception and what contraceptive providers know about bariatric surgery. So I just really felt there was a disconnect. And when there's a disconnect, there's always a really good research question there. So I designed 2 surveys, one for each group. Again, it was mixed methods, and I collaborated with a range of clinicians to learn from them and really try and understand and build the research and clinical knowledge. So I was really trying to be open and not having assumptions about the area, which is really, really hard when you're passionate about it. And when you have to sort of step back, it is tough, but it's got to be done. My next publication was in obesity surgery, and so the findings of the 2 surveys were written up. That was published in 2017, but we're still really no further, probably like Jane, it's sort of an ongoing debate. So we can have contraception and psychology. There's 2 brilliant contentious issues there. But I would say in terms of myself as a researcher, once you sort of start publishing, there's no good having something in a journal, filing it on the shelf and just having it go. You need to be doing something with it. You need to be taking it forward. And I think also you need to get up and you need to start talking about your research. That's how you build collaborators. That's how you get different perspectives. So again, I presented at BOMS, and then I was invited by one of my family planning doctors to go to the British Association of Sexual Health and HIV. And then so there's a whole piece of work around anti-HIV and bariatric patients. If anybody wants to take it on, there's an amazing, amazing project there. I also had opportunities to speak within the trust and the university with respect to my presentation. So there was different audiences, and again, you get different types of feedback. And I found I got an awareness of issues from different perspectives that I think had I not sort of stood in front of people, I wouldn't have had otherwise. I found a load of amazing collaborators, so I would get emails afterwards, and people come up to me afterwards and say, well, we really want to do that too. And I thought, fantastic, because I don't have time to do it. So if there's more people that get involved, we can get more research done. And the more collaborators we got, we can grow and increase research. And sort of through this sort of network, I was able to identify grants and other sources of funding, because if I don't have money, I can't do research, and I love to do research. So part of sort of the hard bit of the job is really trying to find and sell and write funding proposals that people actually want to fund. And that probably takes up 60% of my time. That's the hard bit. The research is the easy bit. But I would say sort of going through this process really helped to build my confidence. There's also a lot of research development opportunities through the National Institute of Health Research. And again, please don't ever think, I was at a meeting with the NIHR before I came here, please don't think the NIHR is for an elite bunch of clinicians that do research. We have a national research agenda. Has anyone heard the term NMAP? So that's nurses, it's an NIHR term, but it's nurses, midwives and allied health professionals. It also extends to pharmacists, psychologists, anyone who's not a clinician. And that clinical research environment traditionally is dominated by medics, but the NIHR is aware of that, and we are trying to sort of level the playing field and making resources and training available to people who are not clinicians, and I'll give you some links for that. So again, I've had further publications in SWORD and BMJ and sexual and reproductive health in the area. So I'd just say, sort of looking back on me, the tips for success, for lack of better words, is really try and develop a network. It's, you've got perfect opportunity here today. You've got a room full of people. We should all be talking to each other. We're a multidisciplinary team. We need to abuse that and get the different perspectives and get together. Attend research meetings. There's probably meetings within your individual departments, the trusts. There's also a lot of profession-specific national meetings. I know funding and travel time is a really contentious issue for NMAPs. The NIHR is aware of that, and we really, really are trying to do something about that. Twitter, I have to feel I'm not the most sort of socially active person on media, but I do find Twitter is sort of short and sweet. And if you find some sort of groups that you want to follow, because we all follow BOMS, don't we, at Bariatric BOMS, you can get sort of snippets of information. You can follow certain things. The NHR has some Twitter accounts, and again, when funding calls come up, you can find them on Twitter, so you know about them straight away. I'd also say it's really important to find a mentor, if you know them sort of personally through your professional networks, but also many of the NHS trusts. My trust has, our research and development department has a list of mentors who are quite happy to speak to other people, and we're all about networking and joining people up. I would say, the Royal College of Nursing, the BDA, and other professional bodies have research resources, and actually a lot of them have really good smaller grant foundations. So if you want to test the water, they offer a small amount of funding for pump priming or doing small pilot studies, which I would really encourage you to take care of. It doesn't matter if you get £500 or £50,000. The fact you've secured some external money is really what you want. Speak to your trust R&D departments. The NHR funds these departments. There's a lot of great resources, and they love to speak to people who want to do research. So even if you're not research active yet, because you all want to be, please speak to them, and there are amazing resources there. And again, just read widely, reflect on your practice for research ideas, and I would say come out of your comfort zone. I love to speak to my surgeons because I'm qualitative, and they just go, yeah, who cares how people feel, where's the numbers? And I'm like, but you need to understand how people feel. And they go, why do we need to understand? I'm exaggerating to make a point, but it's that healthy debate, because then I have to justify how I think and what I do. And the fact that you think differently is great, because actually sometimes I need to think like you, and I need to go into your world to understand what I do. And it's having that reflexivity between the professions. And I think we are so blessed in bariatric surgery to really have a truly MDT. I know we fight like cats and dogs, but we all really love each other. Anyway, but I think that's really, and I think that's something we need to do a little bit more of. And just really start small. You don't have to do great big randomized control trials. I've not done an RCT. I'm not likely to do one. I do qualitative research, I do mixed methods research, and sort of some of my sort of publications that have had the most impact have been the smaller scale research projects. So don't feel that a smaller project has got less value. Everything makes a contribution to our practice. And just some recommended resources. I appreciate you probably can't see them here, so I'm quite happy to have this circulated. But if you haven't gone on the NHR website, you can go on, you can sign up to it, join the Twitter account, and there is here the NHR Learn website. It's free resources. Anybody with an NHS or a local government or an academic account can sign up to those resources. They're free, there's online courses, and I'd really encourage you to take a look at that. And just thank you very much. Any questions?
Any questions from the floor? Have you found out any information on oral contraceptives and
Yeah. Well, actually, for a bypass, oral contraceptions are contraindicated. If you look, there is something called the medical eligibility for contraception. So there's a US MEC and there's a UK MEC. The US MEC is slightly different, slightly more emphatic, and they rank contraception in terms of, one, sort of is free to use, two, is sort of used, but clinical judgment, three, not quite sure, four, don't touch it. And with a bypass, the oral contraceptive is a 3, with the band and the sleeve, it's a 2.
What's that called?
It's called the UK MEC, and MEC stands for Medical Eligibility for Contraception. If you Google UK MEC or US MEC, they'll come up. That should sort of be the first thing that comes through. But there is also the Faculty of Sexual and Reproductive Health in the UK have produced guidelines for bariatric surgery. But again, if you think the NICE guidelines are really, really loose, these are looser. So again, it is something. But I found one clinical trial where they were looking at absorption of oral contraceptives after gastric bypass, and they registered it, and that was about 6 years ago. And I think they've just thought, nope. So there isn't a lot of evidence out there. But thank you for the question.
Any more questions?
But if you want to talk research, I'm around, the rest of today and tomorrow. I'm more than happy to have an individual conversation.
I'm a surgeon, I'd love to take a yes.
Mm-hmm.
being a surgeon, I'm allowed to be here. Yeah?
Of course you are.
Thank you very much.
Of course you are.
Can I just say something?
Yeah.
It is important. My long time back, my research took me through qualitative and quantitative stuff.
Oh, a surgeon with qualitative
Yeah, no,
research.
no,
You have to stay.
I did it for a while because
Yeah.
it's not known.
Mhm.
But now qualitative stuff is becoming more and more. In fact, it's more
Mhm.
important than.
Yeah, absolutely.
I'm not just saying this to say.
We like him.
No, it's true. It's true.
Yeah, no, I think
The
what,
consent form is also changing to make it reflect a reasonable patient standard rather than a colleague of mine
mhm.
will judge me, and if he is my friend, he'll say yes. If he's not my friend, he'll say. So really speaking, the whole judgment is changed from the consent form,
Mhm.
from the Montgomery case and stuff.
Yeah, I think qualitative seeks to understand
Yeah.
so I look at things. I think you do the best procedures. Put the patient safety first. Decide. It's not up to me to tell you what the best procedure. You tell me what the best procedure is, and what I will do is I will work with the patients. I will work with the staff, and I will tell. I can talk about the lived experience. I can talk about the non-clinical adjustments that people make after surgery, and I think it's about sharing knowledge and looking at things from different perspectives. It's Jane's psychology guidelines in a different way. It just is about understanding, and I just think we're just lucky to work in an MDT environment where we can share that knowledge.
Can I say something else? In Truro,
Mhm.
Cornwall, Truro, we talk about what we recommend. In the end, we let the patient go home and decide what they want, because we say if they own the procedure, they'll do better. They'll have a better outcome.
Interesting.
Unless there is a serious contraindication, and then it's our job to explain it to the patient.
Mhm.
Otherwise, if they're equivocal and they decide for whatever reason, and we've given them time to think, we follow what they want us to do.
You need to have a conversation. And I can do some research about it. No, but I say there's just so much going on, and so much open to debate, and I just really think if we could find some really generous funders, Jane and I'd be in jobs for life, wouldn't we?
We really, if you go to the depth of it, we really don't know. You could see today's meeting about OAGB and stuff.
No, but again, that's why we're really lucky to work in bariatric. We're not short of things to research, which is fantastic. I just think we need to just be doing more of it, from the different perspectives. So, I'll get off my soapbox now, but thank you very much.